Good afternoon, everybody. I'm Jide Menakaya. I'm the convener or the chair of the London region of MANSAG. I'm following our conference last year. One of the things that hit us quite a lot was the whole issue about health inequalities, particularly for the African community. We remember speaking with Professor Patel from the Center for Research Equity, recognizing that was a real problem. And so this year, the London MANSAG will be focusing all our activities and thinking around health inequalities. And so today I'm really delighted to meet and to welcome Miss Georgette ONI. She's a surgeon, sorry, you're talking to pediatric, but not pediatric surgeon. She's an oncoplastic surgeon with a lot of effort and understanding of how perhaps cancer impacts on health of Africans, really, or the African communities in London and around the UK. I also have Dr. Chinedum Madubuko, who will be talking a little bit around sickle cell, and I'll be sharing my experience when I went to Nigeria on newborn care. So without further ado, I'm going to introduce Ms. Oni to give us a little talk about oncoplastic issues in African communities. Georgette, please. Thank you. You're on mute.
Hello, good afternoon. Thank you for the kind invitation. Doesn't matter how many times you do these things, you still end up being muted when you start talking. So thank you very much for the kind invitation. I'm going to give a talk around some of the work that I do in terms of inequalities, not specifically focused on African communities, but the Black community in general. And I am aware that there are differences between African and Caribbean, but because we are generally speaking talking about quite small numbers, I focus the work generally on particularly on Black women and breast cancer. So I'm a oncoplastic breast surgeon, but originally I trained as a plastic surgeon first, and then went on to qualify in oncoplastic breast surgery. And so the totality of my NHS work is around breast cancer and breast cancer reconstruction. And I'm currently a consultant at Adam Brooks Hospital. A lot of the work that I'll be sharing is the work that was done when I was a consultant at Nottingham, and I'm an honorary assistant professor at the University of Nottingham there. So just firstly, a bit about plastic surgery, because I think sometimes plastic surgery is a little bit misunderstood in terms of what we do. I think people think it's all nip and tuck and cosmetic work, but actually in the NHS, we do an awful lot of work in relation to reconstruction. So we do a lot of hand trauma. We do pediatric and adult burns. We do head and neck cancers, head and neck reconstruction. We do skin cancer. We do cleft lip and palate. We do a lot of trauma, like lower limb trauma. And of course, we do breast reconstruction. So a lot of microvascular work, a lot of reconstructive work. And really, you don't get to do any kind of cosmetic work anymore in the NHS. So I always describe myself as a little bit of a unicorn because there aren't many plastic surgeons that do what I do. There are a handful around the country. And I was fortunate to train at Nottingham, where actually there were 3 of us that did similar work. And I think that this gave an insight not just into reconstructive surgery, but about breast cancer and the impact that breast cancer has on different facets within the community. So as I've said, I do a lot of oncoplastic surgery, and this is basically using plastic surgery techniques to remove the cancer and to reshape the breast. And that's either through essentially a breast reduction operation or by replacing the volume that you take away using tissue from the side. I also do microvascular breast reconstruction. So that essentially means taking tissue from lots of different parts of the body. And generally speaking, we take it from the tummy. That's our gold standard. But we can take it from lots of different other areas, such as the bottom, the thighs, and we can even now use the love handles to reconstruct the breast. So that's all done using microsurgery techniques. And so why breast cancer? So through my training as a plastic surgeon, I always knew that I wanted to do breast reconstruction. And as I started to get towards the end of my training, I found out a lot of my friends who were African or Caribbean background, they were starting to describe relatives who were developing breast cancer. And the thing that was surprising to me is that obviously having done breast reconstruction, a lot of the reconstructive work that I did were in white women who were in their 50s, 60s, 70s, not that many that were in their 40s. And a lot of my friends that were from a Black background, they were describing relatives getting their cancers in their 40s. And in particular, one friend, her husband has got 4 sisters. 2 have now died from breast cancer. 1 has metastatic breast cancer. The 4th sister has had a benign lump removed from the breast, and I expect that she's going to develop breast cancer. And the mother just last year again was diagnosed with breast cancer. So 5 women in the family, 4 of them have got breast cancer. And they've been genetic tested, by the way, and they don't carry the BRCA gene 1 and 2. So it's obviously something that can seriously affect our communities. And the understanding about why you can develop breast cancer, things that you can do to mitigate your risk, is quite important, so that we can try and improve the outcomes in our community. And I do like to, whenever I do breast cancer talks, I like to show this chart. Why? Because it shows quite clearly that we're getting very good at treating breast cancer, but there's a lot more breast cancer. The incidence is rising quite significantly, you can see. But the mortality from breast cancer is dropping. So that means that you are likely to survive a breast cancer incidence. Also means that we're going to see a huge population of women who are coming back with their recurrent disease. And that's going to have ramifications in terms of the services that we provide in the NHS, but not just in sort of what I call non-surgical treatments, but also in the surgery that we're providing. So it's going to start to kind of weigh heavily on the NHS because we're actually getting very good at treating breast cancer. And why are we? Well, that's because it's for multiple factors. So there's the early diagnostics and the benefits of things like the screening program, better understanding of the cell cycle and where we can target those treatments, and obviously the evolution of those treatments. And right now, there are a plethora of treatments that we can use for breast cancer. And it can be quite personalized. So the pathway for breast cancer patients has become extremely complex. We're also getting very good at treating metastatic breast cancer. And the family that I just talked about, the one that has metastatic breast cancer, she has now had it for at least 10 years and is in remission. And so, the 5-year survival is now 25%, which is very good. But there are differences in terms of survival in relation to age and ethnicity. And Black women have got poorer survival outcomes despite their much lower incidence. That being said, overall survival has dramatically improved, and the mainstay of that treatment is systemic, but we are starting to see metastatic women coming through for surgical treatments. So we know that there are inequalities of health. We've been talking about this for a very, very long time, and so I often think, well, surely they're not existing anymore, because at the end of the day, we've got an NHS here which is free at the point of entry, and we're getting apparent budget increases year on year. We've already talked about the fact that there are a plethora of new drugs that are coming onto the market, and these are vetted through NICE, both in terms of effectiveness in terms of both outcomes and cost. We've got centres of excellence, many of which are in London. And then, of course, there's the levelling up agenda in which we're supposed to be addressing all these social determinants of health. But we know that for Black women in particular, despite, as I've said, their low incidence of breast cancer, they are developing breast cancer at a younger age. They're more likely to develop triple negative breast cancer, which we know have got poor outcomes generally. But across the board, they've got poor outcomes for both invasive disease and precancerous change. So precancerous change, technically, is not supposed to kill you because it hasn't developed into invasive cancer yet. However, there are studies that show that Black women do worse in relation to that too. So if we look at the UK data, and this is actually the best that we have, but it's pretty old now, you can see that very few Black women do develop breast cancer, but the median age at which they develop it is 50. So if you think about the screening program, that starts at 50. Well, over 50%, so about 50% of Black women are developing their breast cancers before they enter the screening age. So this is another thing that we need to think about in terms of how we target our health awareness campaigns. And when they do develop that breast cancer, as you can see, they get it younger. They're less likely, therefore, to have it screen detected. They're more likely to be symptomatic. But also, if you look at the red bar, which is really the important thing, because that is the grade, which is related to aggressiveness of the disease, you can see that for Black women, they always present in more advanced grade. So they say more advanced grade, more advanced stage, more advanced in terms of nodal involvement, and younger age. So why do Black women have worse outcomes? Well, a lot is said that it's due to late presentation. We don't like going to the doctor, and therefore we only present when we're in extremis. Or there is actually data to show that we are unlikely to present through an emergency pathway, more likely to go to the doctor for our diagnosis, the GP practice for our diagnosis. Is it related to poor screening uptake? And we know that Black women have got very poor screening uptake. Is it because we are more likely to be overweight? And we know that there's a correlation between that. Poor engagement with our healthcare professionals. Is it cultural? Is it related to our beliefs and religious beliefs? Or is it the biology of cancer? I think we don't really have a handle on it yet. And what is gratifying and encouraging to see is that I've been doing this probably for the last 5 to 6 years, there has now been a renewed interest in this, and there is starting to be a lot more research looking into the ethnic differences and why we have a variation in outcomes. So why all this fuss about 4% of the population? And that's because actually, yes, we're 4% of the population in the UK. So the recent census shows that we're just under 4% of the population in the UK. But actually, we may be a minority in the UK, but we are a majority worldwide. So there's 1.5 billion people on the continent of Africa, of which 1.2 sit in the sub-Saharan part of Africa. And if you add up Europe and North America, we still beat them. I mean, 1.2 billion population, 8 billion people in the world. So there is now a growing understanding that we cannot just extrapolate what we find in the Western world to all populations around the world. And there is emerging data that shows that actually some of the drugs that have been developed for breast cancer treatment aren't effective in certain ethnicities, and they were woefully underrepresented in the clinical trials. And that's a whole different talk on why we don't get really good buy-in when we do clinical trials that are supposed to be multinational. They still tend to be very Eurocentric in terms of the recruits into multinational trials. So why is this our problem? Well, health is wealth. The cost of the economy is something like 2.8 billion per year. We've already said the NHS is free at the point of entry, but actually, if your breast cancer treatment is performed in stage 1, it costs about £6,000. But if you're now presenting in stage 3, which basically means you've got nodal involvement, it's now costing around £13,500, so more than double. So it makes health economic sense to be able to treat people at early stage grade, and obviously it's the right thing to do. So we have just had a census not that long ago, and if we look generally speaking, across the country, there's like a good distribution of white people. So you see them in Wales, you see them in England, you see them all around the country, essentially. But if you look at where Black people live, the vast majority of them live in London, with a little smattering in the West Midlands. So this starts to give us information about where and how we should be targeting any health sort of awareness type campaigns, because if the issue that we have is that we have poor screening uptake in London, then that's really big, and we have a large population of Black women in London, then we really need to be thinking about how we target our health campaigns and where we target those health campaigns. And the data of screening is pretty stark. Quite frankly, across the board, we are terrible. We're not that great at screening. So we are aiming for 70%. And if you look at last year's data, literally no region in the country hits that. It is starting to improve, but London is the worst. So we know that London is dense for Black people, and we know that with poor uptake, it's not just in terms of, so screening is useful for us even though we know that we present at a younger age. So we need to be able to engage not just with screening, but also in how to self-examine and knowing and understanding the routes to be able to get a diagnosis and therefore early treatment, even if you are symptomatic. So the interest really into this really stemmed from COVID, because we saw in COVID that actually there was very stark health inequalities in terms of who was dying from COVID. And I had done some trial work as well as some other authors. In fact, Tanimola Martins, who was first author on the paper looking at population-based presentation for ethnic inequalities. He actually presented at the conference I organised earlier this year, and he's done quite a lot of work looking at ethnicity and the facilitating barriers to diagnosis across different cancer groups in this country. But we know that there are variations, and I myself have done systematic reviews looking at it, not just in terms of screening, but also in reconstruction, and they're very consistent themes. There's issues around education, access, and fear. So in terms of education, we're unsure of our symptoms, we're unsure of family history, we're unsure about what things are risk, what things are risk factors, how we reduce those risk factors. There's issues around access, difficulty getting appointments, being believed appointments, general distrust of the healthcare professionals. And there was one conference I attended recently in which a patient was saying that actually, you know what, my GP practice, I have to call at 8 o'clock in the morning to get an appointment. If I try calling at 8:30, there's no way I'm getting an appointment. At 8 o'clock in the morning, I'm trying to get the kids ready for school. I've got, you know, an elderly parent that I'm also looking after that I need to try and sort out. So it's almost impossible to be able to call bang on 8 o'clock to get an appointment. Well, if this person feels a lump, how are they going to get early access to their GP to be able to then refer them on to a 2-week wait and then, you know, with the diagnosis? So there are issues around access. And then when you get that appointment, I've heard countless stories of women that have gone and have been told, oh, you're too young to have cancer. So there's also this understanding that you can develop a breast cancer when you're young. It is not common, it is extremely rare, but it does need to be investigated. There's a lump that is persistent, it needs to be investigated. And I do think that that message is getting across. And then there's the fear. So there's the personal fear, the fear of diagnosis, the fear of what a diagnosis will mean, the fear of stigmatization in the community, and definitely fear of what the treatments are consistently. And actually, it doesn't really matter what ethnicity. Whenever I give a diagnosis of breast cancer, every single woman asks me 2 questions. 1, are they going to have chemotherapy, and are they going to lose their hair? And 2, are they going to have a mastectomy? The vast majority of women are not going to have chemotherapy and are not going to need a mastectomy. So there's a lot of work that needs to be done around understanding what breast cancer treatments are and why, if you present early, you're unlikely to need the more aggressive treatment. So inequality can mean many, many things. And I think that there's always that intersectionality, and this is what makes it a very complex problem to solve. There's socioeconomic things that we already know about, things like drinking, smoking, finances, the environment in which you live. There's disability, there's languages, and I'm sure lots of you work in communities where there's multiple languages that are spoken by different people that attend your practices. There's age. Right now, we're going through a whole digitalization of our life. And I think, you know, unfortunately, I'm now at the age where I remember where there wasn't any internet, there weren't mobile phones, and now everything is done via internet or via mobile phone. And that has ramifications in terms of the way, again, people can access care. You can't even go to a bank now. Most things are done online. And this has had a very big effect on elderly people who've done most of their banking throughout their life with cash or checks or going to a teller. And then there's the postcode lottery. So depending on where you live, you will have different access to different treatments. Where I was in Nottingham, breast and plastics were on one site, but I've got many colleagues in which breast and plastics were on different sites, which meant that access to reconstruction was actually quite limited, that it's only available to those that were in their locality. So this whole level up agenda, I mean, obviously through COVID, we started to look at how the way in which we deliver healthcare can have an impact for better or for worse on our patients. And one of the things that they really tried to push quite heavily was doing video consulting or virtual consulting. And we saw quite early on that it may be problematic for our patients. And we basically surveyed the patients that were coming to our door to find out what access they had to be able to conduct their healthcare digitally. The vast majority could only have access to a smartphone with a camera. And actually, while about 50% could use technology independently for any job, another 50% either needed help, didn't have access to help, or had never even attempted to use it. So that's quite a huge population that need help being able to access digital healthcare. And we asked, do you prefer telephone or video consultations? Do you prefer face-to-face? And overwhelmingly, most people preferred a face-to-face consultation. We also looked at different ethnic groups, and we tried to find out what were the reasons why people were, what is the understanding around breast health and about breast cancer and how you access help if you think that you've got a breast problem. And again, there were similar themes across all ethnic groups. Low level of knowledge, but despite that, there was a desire to have credible knowledge. So where are the information sources that I can go to that are culturally sensitive, that are appropriate? And there was a big emphasis on things like modesty and dignity that weren't so negative, a lot of negative messaging around what it means to have a health problem like a breast cancer. And also want knowledge that took into consideration things like religion and culture. So there was a very poor knowledge actually about the prevalence and or the risk of breast cancer in relation to ethnicity, because these things were just not discussed at home. And they weren't, across the board again, unsure how to self-exam or what symptoms to look for, and a very low awareness of what screening, not only what screening was, but when it was supposed to occur, how often it was supposed to occur, and even actually what happens when you go for a screening mammogram. So very low awareness of screening, and a very mixed response to how the healthcare professionals interacted with them. So some had a very, very good experience, but others not so much. So we adopted a multi-pronged approach to look at this in terms of the way that we have the relationships with the community, the understanding that there were different languages and how we can overcome that barrier, the consistency with the information that we were given, and obviously this, the way that things are, we need to look at things that are economical and environmental friendly, and also future-proofing, because things are changing at such fast speed. How do we then change the information that we're giving? We did some community work, talking at local groups. So this was a Gambia Day. We came, like the breast care unit and the nurses, we came with our models. We had a stall just behind there in that cage. They're actually running a football match, and we got people to come and learn how to examine their breasts. We gave them leaflets. And I think they found that being within the community activities helped with that. And there were, other things were there, like, people talking about like blood donation and things like that. Similarly, this was done at a mosque recreation centre. Again, lots of information about how you examine your breast. We even brought some implants and things so people understand about reconstruction and about what it meant to have a mammogram and what the screening programme was about. But artificial intelligence is the big thing, and obviously we're looking at the ways in which we can utilise that. And right now, a lot of the progress that's been made in artificial intelligence is around diagnostics. And so things like how can we use AI to help us read more mammograms so that we need less radiologists. But my interest was in how that we can use it in order to be able to help with the treatment and management of patients as opposed to diagnostics. So we were gifted some software by Roche, which was basically you could build avatars and educational videos for patients. And we used it at the Breast Institute for developing some videos, which we gave to patients post-surgery with instructions for things like how to do their arm exercises, how to measure their drains, and how to look after their wounds. So this is just an example. I don't know if can you hear that? Can you hear it?
No.
You cannot hear it.
No.
That's,
Can you hear it at your end?
I can hear it. Yeah.
Hover around the speaker area to your right.
Can you hear it now?
Oh, no. I heard a voice somewhere. That's somebody. Oh, that was somebody else online. Okay.
Hover around the speaker area to the right and see if you can increase the volume there.
I'll just take my earpods out.
Can you hear it now? Watching this video.
Yeah.
Let's just wind it a little bit.
Presented in this video was created by the clinical team at the Breast Institute within the Nottingham University Hospital Trust.
So using this, we were able to then embed videos showing them exactly what they needed to do. So that the avatars, well, I call it static because it just moves the mouth in relation to speaking. So we embedded videos to show. But what's really great about this is if I have a patient of a different ethnicity or language, I can change the language.
इस वीडियो में पेश करदा मालूमात को नॉटिंघम यूनिवर्सिटी अस्पताल ट्रस्ट के अंदर ब्रेस्ट इंस्टीट्यूट की क्लिनिक.
Or, if I want to make the video so that it's, there's lots of data that shows that if someone looks like you, you're more likely to take on board what's being said. So I can change the ethnicity of the avatar.
The information presented in this video was created by the clinical team at the Breast Institute.
So it's great. So you can change it. So it was nice in that you can change it to if you need a male, if you need a female, if you want language. So I had it changed into Mandarin, Cantonese, whatever language for the patient. So that's ongoing work. We're assessing that. We're actually presenting that at the Association of Breast Surgery meeting next month, actually, in Bournemouth. So also do a lot of stuff on the national level. I've been involved in podcasts for the Royal College, for Black Women Rising. I've been in an exhibition which explains about how cancers metastasize. So it's basically for the public so they can try to start to understand kind of how science feeds into everyday life. Lots of conferences we get involved in, talking about kind of what we're doing from a healthcare professional perspective. So with third sector workers, with charities. And I run an annual conference called the Let's Talk About Black Women and Breast Cancer Conference. Last year, we were in our 5th year. lots of sponsorship from some, big organizations, which is really quite nice to see. We've got charity sponsoring, we've got farmer sponsoring. And I feel like it's unique in that it's basically the faculty is both healthcare professionals and people with lived experience or patients. And so it's very much about two-way learning. So it's not just about healthcare professionals delivering information, it's also about patients delivering information for healthcare professionals to learn from. And I think that people actually find it, I mean, a lot of the feedback we get, and I'll share some of it with you, has been really positive. We have updates on things, so last year we had updates on provision of wigs for Black women, provision of prosthetics for Black women. We've had updates from charities and what they're doing to try and broaden their approach to people from different ethnic backgrounds, because a lot of the criticism is it's great if you're white, you know where to access stuff, but if you're not white, it's actually really difficult to know how you get extract things from charities and third sectors to help you in your breast cancer journey. And it's very practical. So in the afternoon, we have a lot of workshops. We teach people how to examine breasts. We bring mannequins. We teach people how to examine breasts. We teach people about breast cancer treatments. We hold workshops and things like how to survive, how to live after your diagnosis. So when you've completed your treatments, how you move forward. And if you've been diagnosed with metastatic breast cancer, we have a workshop specifically on that. The workshops are run by one healthcare professional and one patient. So there's always that shared learning. And these three women were actually involved in the conference. These have all been women with breast cancer, and sadly, all of which have now passed away. And Della in the far corner there, Della was amazing. So she did a lot of work in terms of trying to increase people's, particularly within the Black community. Della was Nigerian, in the Nigerian community, about research and getting involved in breast cancer research. She did a lot of work with Macmillan. She did work with Cancer Research UK. She did work with some of the prosthetic fitters, so that you can see that you can get prosthetics in different skin tones. So all of these women were really, really instrumental in helping me get the conference off the ground. And sadly, all have passed away from breast cancer. So the content is that we've had 3 in-person events now, 2 online because of COVID, and I've talked a lot about what we tend to cover. But one of the important things, I think, is we do a lot of myth busting. So what are all the myths? We get people to send in their questions. What are the myths that they have around breast cancer risk, and breast cancer treatment, so that we can just squash those, so that they can understand what the actual true information is, what the risks are, and how they do their risk modification, and the importance of talking. So knowing within your family, what are the diseases? We all have relatives that died of something and we're never really quite sure what it was. It's actually really quite important to know what is happening within the family to understand what your personal risk is and the risk that you pass on to the next generation. So this was the first year conference. This was last year. And what we've seen actually is there's been a really good intake in terms of healthcare professionals that attend. This is at the Royal Society of Medicine. The first year we did it at KCL campus. And as you can see, we actually get a lot of healthcare professionals come, but also members of the public. We get charity sector workers. We get people from pharmaceutical companies that attend. And, to be fair, quite a lot of them do know about some of the signs and symptoms, or they know someone that's been diagnosed with breast cancer. And there is some knowledge about how you access treatment. But when we But when we actually looked at what do they know about Black women and breast cancer, not so much. So I think a lot, what the conference gives is a lot of information on the nuances that are specific to Black women. It increases their general knowledge about breast cancer, but also about the unique challenges of breast cancer to Black women. And a lot of them agree that the conference had taught them something new. And what's gratifying to me, obviously, is 100% would recommend the conference to others, but obviously I have not swayed that in any way, shape or form. And so this year we did something a little bit different as well. We decided we were going to do something for World Cancer Day, and because the theme was closing the gap, so all around inequalities. And what we're trying to do is we're trying to raise awareness generally about cancers within the Black community. And so we had a conference back in February, which was co-run actually by the students at KCL. So this is another thing that I like to do. I like to get students involved so that their interest in health inequalities and how they practice when they become qualified doctors also has that in their mind. Because I'm sure a lot of you who went to medical school around my time will know that the curriculum was very, very white oriented. So when I came to start realizing that Black people get diseases, it was actually a shock to me as a healthcare professional, let alone to the community, because our curriculum is very kind of white facing. you know, because we're in a majority white country. But as the country becomes more and more diverse, it's actually really important that the curriculum changes to reflect that. So I like to get the students involved in this. Also, because when I did a study of the medical students at Nottingham, which we have quite a few Black students of a Black background, and the Black students have the worst knowledge about breast cancer, breast screening than any other group. So again, another reason why I tried to get them involved in it. So we had about 190 registered. It was online and in person. And again, had a mix of healthcare professionals, the public, students, charities, and we covered a range of topics from genetics to screening, disparities in cancer outcomes, and we covered the big five. So breast cancer, prostate cancer, gynecological cancers, hematological cancers, and colorectal. And so we surveyed the people, and before attending, they had a reasonable knowledge about screening before the event. But after the event, that increased quite significantly in terms of what the major screening programs were and what they entailed. And also about the cancers themselves in terms of the risk, how to present, the treatments, the management of them. Again, a bit of a spread, some knowledge overall, but actually vast improvement in terms. So obviously this is just a snapshot, and what would be quite interesting to see is how that plays out over time. But certainly it shows that an intervention can improve health awareness. And so let's not forget about the men. I think Beyonce Knowles' father is probably one of the more famous people that we know that have developed breast cancer. It's rare in men. It's 1 in 1,000, 1,500. But again, Black men have got a higher rate of developing worse outcomes from breast cancer. So we have very limited data, but we know that Black men are younger, they get more advanced stage, increased mortality, and socioeconomics plays a role in that. So I think we just, when we're sort of giving those messages, we also need to emphasize that men can get cancer too, and so everybody needs to be examining themselves. So why do Black women have worse outcomes? Well, we've gone through quite a few of the things. I think that it is multifactorial, and I think there's areas in which that we can actually, as healthcare professionals, we can push. So in terms of things like good diet, exercise, not smoking, you know, moderate alcoholic intake, knowing family history to see if you've got a genetic predisposition, you can have enhanced screening, and people don't realize that. But if there is a good, strong family history, you can have enhanced screening for breast cancer. It can start at a younger age, or you can have risk prevention surgery if it's indicated, or preventative drug. But then there's the biology of the cancer. And I think it's actually really quite important that we start looking at the biology of the cancer. The assumption is all cancers are the same, but we are finding that they don't all react the same necessarily. And it's gratifying to see that there is more research being done into this. And I'm involved in one, which is one of the Cancer Grand Challenges. This is a multinational trial. It is looking specifically at Black people of African background. It's going to have participants from the UK, from Africa, and from the US, and they're looking at breast and prostate. So this is, and they're looking at genetics, they're looking at the effect of sort of societal pressures and stresses, and they're looking at the course of the disease. So it's a really, I think they've just got about $12 million to do this research project. So it's a huge project. It's being led by Professor Melissa Davis over at the US at Morehouse, and I think it's going to answer some of the questions that we have around the biology. There's already been prostate data which shows that the genetics of prostate cancer in South Africa is completely different to the genetics of prostate cancer in Europe. So I think that this is what we're going to need to do increasingly, is we cannot just go one size fits all anymore. So I leave you with the thought, we know access to care is not equal, but in terms of what we can do as healthcare professionals, we can do our best to level up that playing field for people. Thank you.
Wow. That's amazing.
Have I stopped sharing my screen there?
Yes, you have. Thank you so much.
Okay, great. Great.
You need to
How do I make sure?
push it. No, you just pull up, pull down. Yeah.
Cool. Can you see me okay?
Yeah.
Yeah.
So thank you. We've got some colleagues online as well. So but I think that was a real tour de force, I think, and congratulations for the work you've been doing. There's some things there around sort of identifying cancer, managing cancer, and of course for the future. So I think Onesi has raised his hand, so maybe he has the first question. Onesi, please. Can you hear us?
Yes, I can.
Fabulous. Put your camera on.
Okay. Just trying to do
There
that.
you fabulous, cool. So you're one of those who have access. So you don't
Yeah.
need extra training.
I don't have a question per se. I just want to say thank you for this lovely presentation. I live and work in Manchester, where we have about 12% of the population being Black. And we're also trying to, with your permission, Dr. Menakaya, if you don't mind, we're planning the Mansan Conference, which will be happening in October. I don't know if you'll be happy to avail yourself to talk on what you've just presented. Essentially, the theme we're working on is the future of healthcare, and we also have a plenary session planned to look at the use of AI in healthcare. You've touched on health inequalities. The health inequalities was what attracted me to attend this today. And more so, you even have looked into the use of AI in healthcare. We will be blessed if you're happy to make yourself available as a resource person in Manchester come October.
Okay, depends what the date is, because I've got a couple of conferences that I'm doing abroad. But if I can't go, then I will definitely send my the junior doctor, who actually, to be fair, he did most of the work, not me. He built all the avatars, he sort of embedded all the videos and things, and he's presenting the work at ABS in May. So if I can't make it, and he's Nigerian as well, so if I can't make it, I will definitely send him.
We'll be happy.
Time to start building them up so they, the next generation starts, getting infused to do this kind of work.
That's great. I'll send you the details. Thank you very much. And I wish you success in everything you continue to do.
Thank you. Very kind.
Yes, yeah.
I have a comment, Kennedy. Just bring it down somewhere. Okay. Yeah, I've got a comment. Thank you for an amazing talk. It's really quite inspirational. I'll turn it around so everybody's seeing, not just me. It's really quite inspirational, and in the true spirit of what I understand, Jide is trying to get in London Manside. It's not just about learning what you've told us. I mean, there's a lot of information today that I actually was shocked not to be aware of, and considering my very first cousin, who was only 4 months older than me, died 8 years ago of breast cancer. It's really quite poignant and very, very painful, because I think she was just in complete denial, to the point where apparently she didn't tell her husband, she didn't tell anybody till she was in the terminal stages. So I can imagine that if she had availed herself, and she's not a complete illiterate, if she had availed herself of this information, she would probably still be with us. And so this matters to me at a personal level. And secondly, what I take from what this talk is I'm thinking to myself, there is a lot of transferability to other specialties. So for example, glaucoma is a condition that afflicts mainly Black people and mainly people of West African extraction, whether they're in the Caribbean or still in West Africa or in America. If you're Black and of West African extraction by genetically, you have the worst glaucoma. And we're the ones who have the worst screening, even in this country, and present late and present extremely young, because generally we get free screening for free sort of eye tests from the age of 40. No, you tend to need your reading glasses from the age of 40. So in this country, you go to the optometrist and glaucoma gets picked up in 2% of the population at 40 and 10% of the population by the time you're 80. First, we tend not to go to the optometrist, and worst, we get our glaucomas from 25. I mean, I've had a glaucoma 23-year-old who'd already lost vision in one eye, Black African. So I see this for me as transferable, and what I'll ask people to think in their own minds is in their own specialties, what's transferable here for them, and how can we support each other in our professional development. For example, what I take from this is that avatar, and I'll be reaching out to you directly at how I can use that technology you've got to educate my own population of patients in whatever it is I want to educate them about. So not only have I listened to this breast cancer talk, I take away what I can then, how I can transfer it to my practice. And thank you for that.
Thank you.
Oh,
Thank you.
No, thank you. And I think that's actually the key, is that we actually like learning things. I think as a community, we actually do like learning things and the education of things. But I think it's more receptive when it comes from people that look like us. And so, you know, it doesn't have to be big groups. It can be little groups that are getting that information that they can then filter out, you know, in their own families, in their own living rooms, etc., etc. So, and the other thing that I found actually quite gratifying is that there are people that you didn't think would want to help have actually been really, really very helpful. And I thought the whole kind of like George Floyd BLM thing would be like a phase which came and went within a year. But actually, I've had sponsors for this conference year on year on year. And in fact, they reminded me, they're like, when is your conference? We need to put it on our like roster of things that we sponsor. You know, these guys have a lot of money to sponsor stuff. So, you know, I think if you're thinking about planning things and stuff that's going to do sort of educational delivery, get really chummy with the reps. The reps come to you all the time for different things, and just get chummy with them to be able to say, okay, we want to fund something that's educational.
And another thing is getting the young ones involved, getting the medical students involved.
Absolutely.
And that really steps then on what Jide has been saying a lot about sponsorship, networking, and what's the word you use? Sponsoring.
And it's great for their CV. And, you know, lots of them have publications, presentations, managerial experience in doing these things. So it's actually very good for their CV as well.
And it's very much just a question of them watching at these events, but also us making ourselves available with whatever skills we have to support them in actually making these ideas they've got, and including the ideas I now have, a reality. Thank you.
Not to worry. So we're going to stop it here now, Georgette. Thank you so much for wonderful, for the real. I know you've got to leave now, but
I do. I'm very sorry.
Together and sort of taking up some of the comments there, particularly around outreach. I think we want to look at outreach, you know, and target outreach in a much more specific.
And actually, while we're on that, actually, just very, very quickly. So there's a group from Nigeria that have got a FET grant to be able to help with breast MDT working. And one of the things that we're really, really desperate for are any radiologists or pathologists who would be interested in doing some educational stuff. So for breast interest, there's going to be some educational workshops that we're going to deliver in Nigeria and Ghana. So if you know anyone that might be interested, please send their details my way. We really desperately need pathologists, radiologists, oncologists as well, that have a breast interest.
Okay, and that's where MANSAG is there for, because MANSAG can get all those people together.
Yeah, that'd be fantastic.
Thank you. Thank you so much. Thank you. Have a good afternoon. Bye-bye. Bye-bye.
Because I think what's really good about stopping the recording is that you don't cancel, you have to save it. Yes, you want to go yes. Then you have to make sure you save it.